Thank you for the opportunity. The connection here was made by a very dear, old, close friend, Dr. Becky Wang, who has recently joined your staff as your Director of Quality. Do you know everyone, Becky? Can you just say hi?
Hi.
Becky and I worked extensively together at the Medical College of Wisconsin. She heard I was coming and asked if I could stop over here and give a talk on hospital-based palliative care. My career started as a medical oncologist. I was interested in neuro. And within a very short time in my academic practice, I came to recognize that we were really good at doing cancer diagnosis. We had all kinds of treatment options available to people, but when things went south, we didn't have a lot of services to help patients and families through the process. Not just at our particular hospital, but this was certainly a nationwide issue. So about almost 20 years ago, I sort of made a career switch and decided that what I really wanted to do was bring the principles of hospice medicine into the academic environment. And that's what has guided me for the last 20 years. About 10 years ago, I stopped doing chemotherapy. I still see plenty of cancer patients, but now about half the patients I see have a non-cancer diagnosis. And I've spent the last 5 years working to help other hospitals develop palliative care programs. So before I go further, what I wanted to ask the group was to think for a moment, and what do you find most challenging, difficult, anxiety-provoking about caring for patients near the end of life? In any way you want to describe the word near. And I'll take responses.
Dealing with family.
The comment dealing with families is always the first comment that I hear when I ask this question, particularly for group of physicians. And can you elaborate on what you mean by dealing with families?
I think that especially when you're talking about somebody who's eligible for palliative care, there's often confusion as to goals. So sometimes the family has one set of goals, you have a different set of goals, and trying to get them to match up. Sometimes the patient has a different set of goals than the family does. There are communication issues. Often there are multiple family members. They all want their own, 30 minutes to express themselves to what they think should be done. There are often family members who are in different parts of the country and dealing with either arranging for them to come or communicating in that way.
I get the picture.
Okay.
Lots of family stuff, lots of communication stuff, lots of conflicts over goals. Anyone else?
Pain issues.
Pain issues. Okay. Yes?
I think there's sometimes misunderstanding of the patient and family with chronic illnesses. How many times we can patch them up after an exacerbation and they're going to be just fine. Sometimes they don't realize there's a limit or that there's sometimes an end point and how many times they can be made better.
Yes. Good point. What else? Yeah.
I had a friend who dealt with an oncologist because she was disappointed that he did not give her enough time to have her mother palliated. That he kind of worked up to the very end and she was caught off guard, not kind of thinking that her mother should back off on the treatment and have some palliation.
So the family felt unprepared to do that. Okay? Any others? Yeah, thank you.
My own not wanting to go see the patient that's dying.
Because
I'm getting old.
Yes, that's a problem we all seem to face. Okay, let me spend a few minutes talking to you about the landscape of hospital-based palliative care and where that fits in the current continuum of medical practice. We're going to talk about the status of palliative care. I'll then talk a little bit about prognostic criteria, particularly in cancer. And then we'll spend the bulk of the time talking about an approach to the family meeting to help settle on what the goals of care are. We're probably not going to get to the futility debate, but I'm happy to answer questions about it. Anytime people want to interrupt with questions, comments, concerns, objections, just raise your hand. I'd like to keep things interactive. So what is palliative care? There's little that will garner more discussion in my world than trying to make a definition of what the world palliative care is and how does it differentiate from hospice and what does it mean when we talk about palliative chemotherapy and how do all that fit in? The current scope of palliative care, first of all, is now a medical specialty, and I'll talk about that in a minute. And the domains of what that include pain and symptom management, prognostication, communication skills, which includes the application of current ethics and law, knowledge of community resources and hospice rules and regulations, psychosocial and family care before and after death care. So these are the domains that people are tested on and trained in palliative care training programs. Why did palliative care become a movement? When I was in fellowship training 20 plus years ago, there was no term palliative care in the United States. It really arose because of this poor guy. Sick, elderly, strapped to a bed, lots of tubes. And this is frequently the final common pathway for people who die in the United States. If you're admitted to a medical intensive care unit in the United States, you have about a 10% chance of never leaving and a 50% chance of being dead in 6 months. So the medical ICU becomes sort of a last stop. Now, for those of you in the cancer business, that's much less of an issue in the cancer population. They tend not to circle through the ICU as much as non-cancer fatal diseases. But the fact that so many people die in hospitals, and 50% of people die in hospitals in the United States. So if you look at all deaths across the U.S., half of them occur in acute care hospitals. And we look at the predominant healthcare system designed to care for the dying, which is hospice care, and that is almost exclusively outpatient, home-based care. We recognize that there's not been penetration of the hospice world into the acute care world. That's what led to the development of palliative care movement. So it's largely been led as a new model of hospital-based care based on consultation teams, very similar to a consultation service in oncology or cardiology or GI, except that it includes typically more than a doc. So these are typically doctor-nurse teams, often with the addition of social service, chaplaincy, others, depending on how they utilize hospital services. But the doctor and nurse make up the core team. Now, as programs are maturing, we're seeing more outpatient clinics in palliative care and integration of palliative care services through the ICUs and the emergency department. Those are kind of the leading edges in the trends in what hospitals are moving towards for earliest identification of patients whose goal setting needs to happen to try to reduce ending up in the ICU and having that kind of a death. Not to say that people don't know good ICU, but that's one paradigm. This is the kind of model where palliative care fits in. Palliative care should start with the onset of a chronic life-limiting disease. So in our cancer center, when a new patient comes in to talk to the oncologist about chemotherapy for the metastatic pancreas cancer, he has them also see the palliative care team. Why? Because they've always got pain, nausea, coping issues. And we will follow the patient with the oncologist as much as he needs us or she needs us. And we may or may not take over more or less terminal care. It all depends on what the oncologist wants from us and how we can help them. We see patients with chronic neurologic diseases, chronic renal failure. So the model of trying to address these issues as early as possible is now the predominant model that's been approved actually by the National Quality Forum and will be looked at as part of the JCAHO soon-to-be certification. Hospice care is more on the right side of that graph, largely defined because hospice is also a healthcare reimbursement system. As such, there's a box around it, and the box says you only get into the box if what? What are the criteria for a patient to be enrolled in the Medicare hospice benefit? Who knows this? Who doesn't work in hospice here? Yes?
One of the criteria would be a 6-month prognosis.
Okay, so the criteria is, quote, a prognosis of 6 months or less if the disease follows its normal course. What's the second criteria? I'm sorry? It's actually not written that way. It's that the goals of care and care treatments must be palliative in nature. And the term palliative is not otherwise described in the regulations. so that, in fact, under hospice care, you can receive chemotherapy, radiation therapy, whatever you need, as long as the goal of the treatment is not curative. The fact that most hospice programs don't support that and provide that, although some do, is because hospices are paid on a per diem fixed reimbursement system. So like most decisions in American medicine, it's all about money. I want to stop here for a minute and take questions about the differences between hospice and palliative care before I go on. There is no special reimbursement system for palliative care. We bill just like any other hospital consultation. Okay. Growth in the last 10 years, 30% of all hospitals in the United States now report a palliative care program. 80% of hospitals with over 250 beds report a palliative care program. Factors associated with having a program include being a teaching hospital, having a strong hospice affiliation, and location. That is, unless you're in a southern tier state, Texas across to Florida, those states have a low percentage of programs, and for-profit hospitals tend to have a low percentage of programs. So in fact, Kettering has how many beds here? 400, 500? So, and I understand you don't have a hospital-based program yet. You're now in the 20% minority. The literature has data now showing that hospital-based palliative care programs will improve pain and symptom management, improve patient satisfaction, increase nurse staff retention. Why? Because nurses actually find it's rewarding to get involved with these patient populations. Increased throughput, reducing ICU stays by ICU length of stay, by quicker identification of what the goals are, and reduced cost. For hospital administration, this has been a huge selling point, is that you can reduce cost for patients by earlier goal setting. This is a graph of a 6-hospital study that's, it hasn't been published yet, it's in review right now. Shows the cost of the 6 days prior to death. These are for inpatients who died. Patients who were referred to palliative care had a significantly lower cost. The term that's used in our field is hospital cost avoidance. In my own hospital this year, we'll demonstrate about $2.6 million of cost avoidance by getting people, moving them from high-cost ICU beds to other beds that are more appropriate, by stopping the 3 antibiotics that don't meet the patient's goal of care anymore, by not doing the CAT scan of the great toe just because, well, I'm worried I might get sued. By doing all those things as early as possible, all through goal setting, you can reduce cost. You may not know this, I know all the administrators in the boardroom, but hospitals lose money on sick, complex patients who spend a long time in the hospital. Hospitals make money on short-stay, procedure-oriented things. So you don't see, I bet Kettering doesn't have advertisements in town here saying, bring us your really sick, complex, multi-organ failure patient, right? They don't say that. Bring us your hearts, your strokes, your knees, your hips, right? Do we want to sell palliative care on the basis of that it's cost effective? Of course not. That's not a message we want to sell it on. But it's rare in medicine that you can do something that's good for patients and families and actually cost less. JACO is working on a palliative care certification. This will not be a requirement. This will be an added certification. It'll start in 2008. I don't have any details on this yet. There are standards for hospital-based palliative care that have been approved by the National Quality Forum. They will probably form the basis of the JACO certification. And this will be a message for hospital leadership. If you want to be known as having some special service and being a leader in your community, you're going to get certified. So I know some of your competitors in town already have programs in various stages of development. Not that I'm trying to egg you on or anything. What's in it for the doc? There's no easy way I can tell you this, so I'm sending you to someone who can. So the question that I always get from docs is, hey, I do palliative care. I'm an oncologist. I do palliative care. I'm a neurologist. I do palliative care. Why do I need you? And the issue is primary versus specialty care. All doctors should be doing good palliative care. All doctors should know how to prescribe morphine and dose escalate it in straightforward pain cases. All doctors should know how to sit down and run a family meeting. Oh, I wish it were all true. But there is a need, if we even were at that level, there would all still be the need for specialty level care, complex family meetings. How do you work with the families where everybody's arguing with everybody? How do you deal with the complex pain and symptom management? We support doctors through time management by being able to do the hour-long family meeting when they have to be in the office. Our oncology group has come to recognize this very quickly, where they realize that my nurses and my doctor staff in palliative care, if we can do that work for them, they can see 5 more new patients in a day. So they can be more time efficient, and we can support them to do that. Hospice and palliative medicine is now a recognized specialty. The approval came in 2006. There will be a new board exam in 2008 with a grandfathering period until 2012. That means people like me can get reboarded. I'll be reboarded now at HPM without having to do a fellowship. Starting in 2013, you will have to do a fellowship in HPM. You can sit for the boards if you have completed a primary residency in any one of these 10 specialty boards, which is very novel in medicine. There is no other specialty like this. And it was to address the broad reach of where these patients are coming from. There are currently about 55 fellowship programs in palliative medicine. The closest one to you is in Columbus, but there's one at the hospice, at the Dayton VA, which will be starting next year. All right. Before I go on about goal setting, questions about the specialty, the field, certification? Yes, ma'am.
One thing that the network does, Kettering Medical Center is a bit more, is that they have contracts with the top hospice and hospice of Dayton. So we signed contracts like, I think it was in 2005, that there's a person that needs palliative care. We actually sign a contract with the hospital, come in, and that patient can come on to the hospice service, but remain in the hospital bed.
That's totally different than what I'm talking about.
Right, yeah.
Okay. So the goal of hospice programs. So the goal of hospice programs is early referral. So you can get your per diem when the patient costs less. So so that's issue one. Issue two is all hospices have contracts with inpatient facilities for inpatient services if the patient's symptoms can't be managed at home. Okay? So it's good for patients to be enrolled in hospice early for all kinds of reasons, and it benefits the hospice program. But with an external agency doing that, they're only getting patients who somebody's already decided is hospice appropriate. Hospital-based palliative care teams in the hospital work day-to-day with people and are able to identify a much larger population of patients in need of services. 1/3 of the patients we see aren't ready for hospice because they're not eligible, they're still getting active treatments. And then we send them home and follow them home. 1/3 of them we enroll in hospice and get them home, and 1/3 of them actually die in the hospital. So you're talking about overlapping circles of populations. But having a contract with a hospice agency is not having a palliative care program.
Right.
And hospices use the term palliative care as a way of trying to broaden their population base. And we'll try to bring on, larger hospices can do this financially, bring on patients earlier and may pay for chemotherapy, for instance. But it's all under the Medicare hospice benefit. And if I'm confusing people in the room, this is why there's a specialty. Because the rules are so freaking weird. But that's how it works. And we can talk later. Other questions? Okay. Goals of care. So the issue of caring for these patients is how do you deal with the families? How do you set the goals? How do you get to where you need to get to help people through this process? There are really only 4 major goals in medicine. Cure. So if you're treating a new Hodgkin's disease, you're going to work for cure. If it's recurred 3 times, you're not going to be able to cure it, but at least you can give some treatment and try to make them live longer. You can't make them live longer, you can hopefully rehabilitate something to make them more functional, and if you can't do that, the goal is to keep them comfortable until they die. This issue of what is our goal forms the basis of all subsequent medical decisions. Gee, do we keep the pulse ox on? Gee, do we continue tube feeding? Gee, do we start antibiotics for the next pneumonia? The issue always comes back to what is the goal we're trying to achieve. The problems with doing goal setting is that it's time intensive, emotionally volatile. I will bet that very few of any of you here have actually been trained in high-level goal-setting conversations. I know the doctors have been trained by somebody observing and checking them off to say they can do the spinal tap correctly. But very few of us, I certainly never had time, were observed, given feedback, and finally somebody said, yes, you are competent to run a goal-setting discussion. It is the most high-order communication skill in our practice. As such, we're not trained to do it, which is why we often stop it. And we tend to focus on the trees, not the forest. We focus on the new pneumonia, and we don't focus on the fact that, yeah, it's a new pneumonia in the setting of progressive cancer, in the setting of new brain mets. Let's talk about the big picture. Just in a sensitive time, I'm trying to cut through things. Prognosis. In cancer, how many of you here are involved in cancer? How many not? Okay, good. And I saw about half the room didn't raise their hand, so you're just here for lunch. In the world of oncology, we have the best prognostic data to tell patients better than any other disease. And in the last 3 months or so, we have actually really good data. And it all relates to how do you spend your day. The issue of functional status is the best predictor of survival in advanced progressive cancer. Patients who are ECOG-3, that is spending more than half the time in bed, laying down, resting, and it's getting worse, have a survival of 2 to 3 months. Add on physical symptom burden, and the time gets shorter. And the shortest is related to dyspnea, related to the terminal illness, related to the cancer. So we actually have data in cancer that our colleagues in heart disease, lung disease, dementia don't have, because there is no good predictors of less than 6 months survival in those diseases. There are no reliable prognostic variables which can predict a less than 6 month prognosis with greater than a 50% accuracy. That's a flip of a coin for any other chronic disease. And the reason is because of this slide, the illness impact trajectory. The y-axis is functional status, how much somebody can do all day. There's 2 curves. The colon cancer curve, substitute any other metastatic cancer. People generally have pretty good functional status until the last couple of months. And then all of a sudden, they're more fatigued, spending time in bed, not eating, losing weight, and they die. It's a rapid downhill course. The Medicare hospice benefit was largely designed around that paradigm. That's why the 6-month rule was put in there. All other chronic diseases have the bottom graph. Slow deterioration over years, periods of exacerbation, and in the last year, the exacerbations, their functional status never gets back to baseline. I'm sure, we have house staff here? You hear this term all, well, we just want to get it back to baseline. Okay? You're nodding heads. For the patient in the last year or two with a chronic disease, typically when you send them back home, they're not at baseline, and they often never get there. So what you see is this slow progressive downhill course, and at some point they die, and they die suddenly and unpredictably. So how does a heart failure patient die? He's been classed for heart failure for 2 years. Half of them will have an arrhythmic death. So they went to bed at night, they didn't get up the next morning. If they got up the next morning, that would be kind of cool. The dementia patient who's been bedbound dementia for a year, Sunday he gets a fever, and on Tuesday he's dead of pneumonia. On Saturday, you never could have predicted that. So it's much more challenging in this population to define sort of when are they dying. But even though deaths for most chronic diseases are difficult to prognosticate, the concept of saying a patient is dying can be done, and end-of-life planning begun if the following criteria are met. And these are my key criteria. The patient is progressively losing function and or weight despite best medical therapy, and or is requiring increasing medical resources with no improvement in quality of life. That's the frequent flyer. You call them frequent flyers here? Okay. There are always regional stuff I'm never aware of. For all I know, you call them Wisconsin patients. And or the patient has requested no further measures to reverse the current or future medical problems. Now, for non-cancer diseases, this last statement is the most important in determining prognosis. The guy who's in the hospital every month with aspiration pneumonia that you're treating, if he decides, and you decide, we're not going to treat it again, I can pretty comfortably say he's going to be gone in a few months based on his natural history. But if we're going to keep treating his aspiration pneumonia, I'm not sure. It could be a month, it could be 6 months, it could be a year. So the goal of care actually determines prognosis for non-cancer diseases. In cancer, once people are on the downhill slide, there's very little that you're going to do that's going to change that. What do people want? What do our patients tell us they want? There have been numerous studies of this now of people with chronic disease. They all say the same thing. They want control over their final days. They want pain and symptom relief. They want not to be a burden to their family. They want to strengthen family relationships. And they want treatments, but only if there's a goal to be met. And this is very important. People don't want to be treated just to be treated. They want treatment if you can achieve a goal. So at this point, I'm going to stop, and I want you to talk to the person sitting next to you and ask yourself, how well are you doing in this hospital in meeting these patient family needs, what they say they want? Okay, I'm going to interrupt. So, to use the oft-used pain scale, on a scale of 0 to 10, if 10 is we're wonderful and 0 we're terrible, how many would rate in the 7 to 10 range? Raise your hand. How many in the 4 to 6 range? How many in the 0 to 3 range? And the rest of you?
They're here for what?
They're here for What's that? Okay. All right, let's talk about the family meeting. This is where the action happens. It's an opportunity for shared decision-making to set goals. There's good data that patients and families want to talk about this stuff. They actually do want this information, but it can be very emotionally volatile. And in palliative care, we don't have a procedure and we don't have a drug, maybe morphine. Our procedure is the family conference. It's helping people achieve some degree of consensus and ultimately acceptance about what's happening. Meeting leadership. Who should be leading this meeting? It can be thought of as a team sport, and you want the players on the team who can bring the following skills to bear. Group facilitation skills, keeping people on track. Counseling and emotional reactivity skills. What do I mean by that? I mean somebody who can look and see that mom is about to start crying, and it's time to stop talking and address the emotional reaction before going on. It's a crucial skill in these meetings, something we never train doctors and nurses to do very well. Social workers get some training, chaplains get some training, but it's typically not part of much doctor-nurse training. You have to have the knowledge of medical and prognostic information. And finally, a key step is somebody has to be willing to make a recommendation. In American medicine, we have moved too much to the role of thinking that everybody has an autonomous right to make a decision and we don't have a role in making recommendations. That's what they pay you for, is to tell people what you recommend based on your knowledge and experience. We'll come back to this. We're going to talk about a 10-step process that's in a sequence designed to maximize the opportunity for dealing with emotional reactions, getting the facts out, and being efficient. Because if this goes well, it can be 15 minutes. Sometimes it takes an hour. Sometimes it takes longer. It can work well if the patient's there or not there. This is the summary of key steps. We'll go through these, and I'll have them again at the end. Pre-meeting planning. You got to plan what you're going to do. So just like doing a spinal tap, you don't want to put the needle in and then swab the skin. Right? Bad outcomes happen. You got to plan first and get your ducks in order. You got to review the medical history, know all the treatment options and prognostic information. Somebody has to coordinate the medical opinions between the consultants and the primary MD. Or in many times it's just sitting down with the primary MD and saying, what are you thinking about this case? Where are we going? You need to get one medical message. Now, in a teaching hospital like yours, that's difficult. All teaching hospitals suffer from the fact that there's so many people around and people are getting all kinds of mixed messages. I'm sure it happens because I work in a teaching hospital. You want to get the patient family psychosocial data, so you want to know who's mad at whom. You want to know if there are drug and alcohol issues in the family. You want to know if there's major dysfunction. You want to review the advanced care planning documents. My most unhappy palliative care consult that I received was from a patient who sat in the ICU for 5 days, and the request from the ICU team was they wanted to put in a feeding tube, and the family was resistant. Please come help settle this disagreement. I went, opened up the chart, found the advanced directive, which said the patient said no feeding tube. Told the attending physician the decision's already been made. That was primary palliative care. That wasn't specialty care. So bring the documents with you, review them, and then decide what's appropriate. You have to decide before going in there what you think is medically appropriate. What will enhance, improve, what will worsen, or provide no benefit in terms of the patient's function, quality, and time. Function, quality, and time. That's what patients and families care about. They don't care about creatinines. They don't care about LDH. They care about function, quality, and time. You've got to have the right environment. I really try to do these with people sitting in a circle and get everybody to sit down. The most important person to sit down, you, who's ever leading the meeting. Introductions, step 3. You have to take the time and get everybody to introduce themselves. I go to way too many meetings where we do family meetings. Our standard is that we ask the primary physician if they want to run the meeting. And if so, great, we'll support them. If they want us to run it, we'll run it. If they want to run it and they walk in and the first thing they do is they start talking about the medical review, I'll interrupt them and say, let's just go around and do some introductions. It's basic politeness. It also gives you a sense of who in the world you're talking to. Review your goals and find out what their goals are. So the typical goals are, I've asked you to all meet today so we can talk about your father's care and help to make some next decisions. You don't want to start out the meeting and saying, we're here today to talk about pulling the plug on your father. Not a good thing to do. Take a moment to build relationship. Unless you really know everybody around the table, you should take a moment and work to build some relationship. Ask a non-medical question. Tell me about your father. What did he like to do? What kind of hobbies did he? What did he do in the war? Obviously, if you've known this person and all the family members for 20 years, you can skip over this. But otherwise, and this is particularly true for the house staff, who probably don't have 20-year relationships, spend a moment and ask a non-medical question. This pays such dividends because it tells the family what? Step 4, what does the family patient know? Don't launch into the medical review until you've asked this question. Tell me your understanding of the illness. Tell me what the doctors have told me. Tell me what you know about the test results. For anyone with a chronic illness, ask about the last 3 to 6 months. And in particular, you want to know about function. What has changed functionally in the last 3 to 6 months? What has changed about use of medical resources? In and out of the hospital 6 times. Get the family and or the patient to self-describe this, and half of your work is done for you. Because typically they will describe the fact that things are getting worse and things are going downhill. And it's much more powerful for them to say it than for you to say it. We always feel the burden that we're in a rush. We need to get our stuff out. We need to say it. Take a deep breath and let that do the talking. Step 5, medical review. So there's 2 common ways to do the medical review. The first is the most common, and it goes something like this. We get a CAT scan. There's 3 new spots in the liver. There's a new spot in the brain. The pleural effusion is worse. Do you have any questions? Okay, don't do that. What do families and patients want to know? Is Dad getting better or is Dad getting worse? Big picture stuff. So just tell them. Big picture. If they want to know the CAT scan result, they'll tell you. When I teach this to our fellows, and we teach all the oncology fellows rotate with us, I tell you get 2 sentences, that's it. And they need to be short. So we reviewed your studies, the cancer's getting worse. I think time is short, I think you're dying. And this is where I use the D word. You have to use it empathically, but use it and you will solve 50% of your requests for fetal care if you use the dying word. What's the difference between prognosis poor and you're dying? What's that? I can't hear, so. Prognosis poor says you can still get better. Hey, if the ship is sailing and you know they're not going to get better, from a medical perspective, we're not talking about miracles, we'll get into that later. But I always tell people, from what I have in my black bag, I got nothing there that's going to make this turn around. Use the D word. Anybody here ever use the word dying? What's been your response?
I'm glad you told me.
I'm glad you told me. It's concrete. It is unambiguous. What does prognosis poor mean anyway? It's totally ambiguous. No one will misunderstand you when you say your father is dying. No one will misunderstand you. And this is a time when you don't want misunderstanding. We will try not to use these concrete phrases because we're afraid of hurting people. We're afraid that they will lose hope. We're afraid that they're going to get angry. We're afraid they're going to get emotional. Guess what? They might. And is that such a bad thing? A, you can't control other people's emotions. And B, you have no idea how they're going to react until you tell them. So that my experience is the most common reaction, particularly in the cancer patient, is to say, yeah, that's what I thought. Thanks for telling me. This always used to blow my mind. It still does. You walk in the room, you have this big emotional meeting, you tell them he's dying, you talk about time short, and before you walk out, they get up and thank you. It's like, you're supposed to thank me, if I just saved them. But they thank me for telling them they're going to die. So use the D word. It's powerful, it's potent, it's empowering to them. And it gets around a lot of the confusion. I had a lot of family meetings where, we get called because the family's in denial, the family's doesn't accept. You walk in, what have you been told? Oh, this, that, and the other thing. And I say, yeah, that's all true. And, big picture, your dad is dying. Oh, well, if he's dying, then of course we don't want to do X, Y, and Z. Then we need to do, A, B, and C and move in another direction. Okay, you've just given bad news. The communication skill then is to be quiet and wait for the reaction. And because you have no idea what the reaction is going to be, you don't know what your next thing you're going to say is until they open their mouth. Typically, when people talk, they'll talk in one of two ways, either an acceptance way or a non-acceptance way. The acceptors will ask these 3 questions. How long? What will happen? What do we do now? And if they're not asking them, they're thinking them. When there's no acceptance, they'll say this. What are you trying to tell me? How can you be sure? I want a second opinion. There must be some mistake. We'll never give up. I have a strong faith that things will get better. I believe in miracles. Somebody wrote a song about that. So they'll come at you with all these questions. Why?
Very hard to accept that you're dying.
So it's hard to accept. So is it a content deficiency that they just don't understand the information? Or is it an emotional issue? Emotional, very good. Except, how do we normally respond to this? What's our response when people come at us like this? We get defensive. Why didn't they? I just told them and they don't believe me. So your natural reaction is to sort of get defensive and or think that it's a hearing deficiency. Maybe if I say it in a different way, D-Y-I-N-G, they'll get it. This is emotional-based conflict. When you hear conflict, always think emotion and assume that's the issue. It's not an issue of factual understanding. Clarify if you get the sense there is a factual issue. And then the response to emotionally-based conflict is to make an empathic statement. This must be hard. I can't imagine what you're going through. You've really been fighting this a long time. Don't say, I know what you're going through, because you don't know. But do make an empathic statement. And when you make that statement, what typically happens?
They understand.
What's that?
They understand.
Well, first of all, it diffuses the anger in the room because what you've acknowledged is that they're having an emotional reaction. And then typically what happens is somebody starts to cry. This is the time the Kleenex box needs to be present. So this is the time when they're allowed to grieve. So for those patients and or families who are not ready yet, this will get a whole bunch of them over the hump. Make an empathic statement. Generally, you need, we'll talk about what you do if that doesn't work. At some point, you're going to need to talk about the two broad care options. One option is to continue aggressive care, so we could do another round of chemotherapy. We could do another 2 weeks of radiation. Or maybe it's time to withdraw what we're doing and focus on comfort. And it always comes down to usually two big, broad decisions. Again, going back to the two key goals. To help families and patients get to answer this question, the key issue is prognosis. So time, the element of discussing time sort of hangs in the room. So if it hasn't been asked, you need to bring it up. So answering the how long do I have? I like to confirm that people really do want to talk about it. Some people in the room may not want to talk about it. If you have a good sense, tell them. Always do it with a range. Never give them a specific date. You will die on January 3rd at 2 p.m. And then you just give it bad news. So take a moment and address the emotional reaction again. I usually will ask the patient, is what I've just said surprising? And they typically say, no, that's about what I was thinking. If they don't ask about their prognosis, ask them, has anyone talked about time? Press the issue. But don't force it on people. If people really don't want to talk about time, there's usually no reason to talk about it unless the issue of time will impact a major care decision. So if you have a single young parent with a child who hasn't made plans for his child, you need to force the issue. If the patient wants to come back in 6 weeks and then he'll consider more treatment, and you're thinking 6 days, you need to talk to time is short. Making recommendations. Patients and families want us to help them make these decisions. Yet increasingly, physicians are fearful of making recommendations. They're afraid of introducing personal bias, afraid of a bad outcome leading to a malpractice claim, fear of being paternalistic. We have this sort of distorted sense of patient autonomy. So I more and more hear younger doctors say to me, "Oh, I don't want to make a recommendation because that would introduce my bias." Any of you house staff felt that way? Nobody's answering. Okay. If you're making a recommendation based on your medical judgment, experience, and knowledge, that's not biased. If you're making a recommendation because of a personal value, based on a personal culture, religious, whatever it is, that's introducing bias. But if you're making a recommendation based on what you read in the textbook and your discussion with your team and your knowledge of the medical literature, that's what they pay you for. Patients and families want your opinion. They want to be relieved of the burden of decision making. Way too often, what I hear from families is, well, the doctor said it was up to me. If you could do an operation or not do an operation, it was really up to me. That's abrogating our responsibility. Families are put in the position of feeling like they're the responsible person for pulling the plug. And that's not a very pleasant place to be. It's your job. It's your job to help them. Recommendations are considered an aspect of the professional responsibility of practice. In fact, if you look at the AMA's definition of informed consent, it says right in there, risk, benefits, burdens, and making a recommendation. What do you do when the patient can't talk and the family's not sure what to do? You want to get the patient to help you make this decision even if they can't talk to you. What have they written in their advance directive? Or ask the family, if Dad was sitting here today, what would he say? That will cut through a lot of family grief. But where they can't decide what they would do, put it back on Dad. He's the patient. He just can't talk to you. But they generally know what he would say if he were there. All right, you've done all this good work. You've given them accurate information. You've made a concrete recommendation. You've made the empathic statement, and you're still not getting anywhere. They're still pushing you for what you consider futile care. They're arguing. I always tell people, remember these three key things. First, people don't all get there at the same time. Acceptance of dying takes a while. And the key psychological step in getting to acceptance is being able to imagine your life without the other person. And that takes psychological reorganization of your brain. That's why in number 2, a sudden illness is so much harder for everybody to get there because they haven't had the time. In oncology, families generally have the time. Patients have the time. It's why it's very rare for a patient to say they're not ready, particularly the elderly. They're usually there. They're way ahead of the family. Finally, remember that prior family conflicts that involve drugs, alcohol, or abusive relationships make decision-making almost impossible. Those are the families that struggle the most. And your response to them should be a higher order of recommendation. That is, you need to take even a more of a leadership role with those families because there's so much internal conflict. These are the other common reasons why there's conflict. So lack of accurate information, this is still the number one thing I see. Guilt, fear, and anger among families from past family junk. Grief, which is just the time issue of time. Lack of trust in us. Cultural and religious conflicts. And the truly, really bad dysfunctional families. And again, these are the ones where you'll find drugs, alcohol, and abuse. We also contributed to this, and I put here the doctor's contributing features. When we're overly optimistic, when our fear of malpractice, ethical impropriety, peer pressure, fear of mistakes, and prognostic uncertainty gets in the way of helping families get to where they need to get to, all of those things can make things worse. And finally, when we use our cultural values, and I don't mean our physician cultural values, I mean our personal baggage, to try to get patients and families to do what we think is right based on our culture. That's unprofessional conduct. When there's no consensus, A, ensure that everybody has the same medical information. B, ensure that a relationship of trust exists. If there isn't trust, you don't have a valid relationship. Establish a time-limited trial. I do this a lot. So, particularly for ICU patients, family wants to keep pressing ahead. I'll say, fine, let's keep pressing ahead. But we're going to set 48 hours, 72 hours. At the end of that time, the family and I will negotiate, okay, I would expect that things are going to turn around, that by 72 hours we'll see improved X, oxygenation, mobility, cognition, whatever. And we're going to meet again in 72 hours and see if those things have been met. And that really helps families think through that they have done everything. And if things are better in 3 days, well, great, then we'll just keep charging ahead. But if things are worse, the family knows that at least they tried. And that's the other key step for them. Finally, step 9, translate goals into a plan. We've discussed the time is short, knowing that what's important to you. What do you need or want to do in the time you have left? Typical responses are home, family, comfort, upcoming life events, and a colonoscopy. Confirm the goals. So what you're saying is you want to be home, free of pain, would like to live beyond our next wedding anniversary in 6 weeks. At that point is when you pull out the chart And you go through all the tests, drugs, and procedures and say which will help meet these goals and which will not meet these goals. The following list are the things that commonly need to be discussed at this time. Notice DNR status. I always recommend withholding a DNR discussion until you've had the goal of care discussion. Otherwise, you're not really doing an informed consent discussion. People have to have a sense about what's happening to them to make a decision about whether they want you to break their ribs and beat on their chest. This is where the hospice discussion takes place. This is where you decide about, are we going to use artificial nutrition hydration or not? Again, how will these things match to the patient's defined goal of care? Confirm the plan. And finally, summarize and document. Summarize areas of consensus, disagreement, caution against the unexpected outcomes. The dying person doesn't always die. You know, they gave you the crystal ball when you graduated, but sometimes it's cloudy. Provide continuity, document the medical record, and make sure to discuss what happened at the family meeting with everybody who needs to be, particularly the patient's nurse if they weren't at the meeting. Summary of the key steps again, and it's all in your handout. And I think I'm going to stop there. Time is getting short. Take some time for questions, comments. Yeah?
You spoke about the importance of a physician giving his educated opinion to the patient or the family. What do you suggest when you have multiple physicians coming to the patient's bedside giving differing opinions?
Yeah, the role of the attending physician is to be the quarterback.
Okay.
And the role of a consultant is to advise the physician on what to do. And the primary physician needs to take control of that communication flow. So they're the person responsible. And sometimes it means telling the cardiologist, hey, I want you to talk to me and let's discuss things before you talk to the family. If you don't take control, you lose control. Family's left, to sort of flounder.
It's very emotionally.
It's terrible. Yeah, it's a terrible thing to do to people. Yeah.
In this hospital and most other hospitals, there are hospitalists admitted.
Yeah.
And there is really not a relationship with the families, and then they have three different consultants who are taking opinions. Who should be taking charge, or who should be consulted before they bring up the issue of palliative care? The oncologist.
Whose name is on the chart?
The hospitalist.
Then the hospitalist is where the buck stops. Now, this patient's had an oncologist for the last 2 years. I sure would hope the hospitalist is in communication with them. And they are together discussing kind of what the best plan of care is. But ultimately, it's the person whose name's on the chart is the attending. Now, it's all about communication. The hospitalist and the oncologist will talk, and the oncologist may say, hey, listen, I'm going to have this conversation. Great. Or say, I can't, I won't, I don't want to be there, I don't have a good relationship with this family, can you please do it? That's where it's got to go through. Again, in our setting, then somebody calls me and says, this is going to be a really difficult one, we need your help on this, can you be at the meeting? That's the kind of place we fall in. Yeah?
You get involved in home care, and how you handle that with the medical background?
Do we get involved in home care? I'm sorry, but I'm confused on the question.
Yeah. Do you get involved in home care? Terminal basis?
And when you say home care, are you speaking about the specifics?
Do you as a doctor?
Yes, I do get involved in home care. Many patients. Are you talking about the home care benefit or home hospice or both?
No, just plain home care.
Plain home care. We use home care services when patients have a skilled need, because that's how you have to justify it for Medicare that there is a skilled need. And we use home care if patients are not appropriate for hospice services or they're not ready psychologically, and if they fall into that group.
So when the patient needs and wants home care,
Yes.
how do you approach that?
If the patient wants home care, if I think home care is appropriate, we'll recommend it.
If the patient wants to be treated at home.
You know, part of the problem is I can't hear you back there. Maybe you can come down after we can talk.
The patient is empathical inside and doesn't want to go anywhere else but to be treated at home.
We'll do as best we can to support them. I'm not sure what you're looking for.
Do you have experience?
Sure, I see this all the time.
Is that related with the hospice care?
If they're hospice eligible and hospice appropriate, we will work hard to get them to get enrolled in a hospice program.
But are there any patients that only require, they want home care? They don't
Sure.
want hospice? Do you get involved with that?
Yes. Sure.
So do you follow the guidelines?
Yeah. Which guidelines are you talking about?
All the
It's the same issues. Having a family meeting is
It
independent.
is more confident for living widow and to have a power of attorney. And that's simple.
Again, I missed half of that. I'm sorry.
Sorry.
Other questions? Yeah.